Hi, hello everybody. I would like to thank Diapat for organizing this webinar and inviting me in this webinar. I would like to present you my own experience in immunohistochemical differential diagnosis of small blue round cell tumors in children. As we know from our pathology books, as we know, small blue round cell tumors is a group of highly heterogeneous malignant and aggressive tumors, usually with aggressive clinical course, and which can occur at any age. These tumors are characterized by similar morphological appearance, that is, small round nuclei and a very narrow, barely visible cytoplasm, and this characteristic is giving for these tumors very characteristic feature. They are gaining more blue color in simple hematoxin and eosin stain slides, so hence the name small blue round cell tumors. Let's see which diagnostic entities we have in this group in children, particularly in children. And the most commonly encountered nosological diseases of this group in children are eight names. First of all, acute lymphoblastic lymphoma leukemia, then Ewingsarcoma, rhabdomyosarcoma, neuroblastoma, nephroblastoma, medulloblastoma, retinoblastoma, and hepatoblastoma. As I mentioned, these tumors can arise in any age. So we distinguish also another 8 entities that are more or less characteristics for adults and the young adults. Those are the small cell carcinoma, Merkel cell carcinoma, non-Hodgkin lymphoma, synovial sarcoma, desmoplastic round cell tumor, mesenchymal chondrosarcoma, small cell osteosarcoma, and olfactory neuroblastoma. Today we are going to discuss the group of small blue round cell tumors that are characteristic in children. So let's go back to our previous slides and see which diagnostic entities we have in this group. As you can see, first 4 diagnostic entities, namely acute lymphoma and leukemia, Ewingsarcoma, rhabdomyosarcoma, and neuroblastoma. Those are very often causing diagnostic and differential diagnostic problems and sometimes severe headaches for the working pathologists and the residents. The last 4 names, you see nephro, medullo, retino, hepato. It means that the names of those diseases implies the strict anatomic localization of these tumors, and usually in the settings of proper clinical data and radiologic data, they are not causing severe differential diagnostics problems. So today we're going to discuss first 4 entities: acute leukemia, Ewingsarcoma, rhabdomyosarcoma, and neuroblastoma. Current WHO classification of acute lymphoblastic lymphoma leukemia recognizes 2 main groups of diseases, namely B cell and T cell. So B cell derived from the B lymphocyte lineage and T cells from the T lineage. Each group then can be subdivided into subgroups according to the different genetic abnormalities and recurrent genetic abnormalities, so requiring more or less sophisticated molecular testings. So I hope my lecture would be helpful for the working residents and pathologists, especially those working in the labs with limited resources and who cannot do a whole spectrum of molecular testings. So let's start with our lymphoma leukemia group. As for the B lymphoma leukemia, we know that roughly 10% of acute lymphoma leukemia cases in children are represented by the B lineage specific type. The most affected extramedullary organs in BILL are skin, lymph nodes, spleen, testes, central nervous system, bones, and soft tissues. And it must be remembered also that the B type of ALL is commonly seen without involvement of the peripheral blood and the bone marrow. So it's commonly seen as an alleukemic types, which must be remembered also. And of course, B-type ALL has a more or less favorable prognosis in children as comparing with the another type of the LLL. It means T lymphoblastic leukemia lymphoma. It accounts roughly 90% of all cases in children, and unlike B-ALL, T-cell lymphoma leukemia has a leukemic presentation. That is why most present with advanced stages with the affection of the bone marrow and peripheral blood. But also it must be noted that the T-cell type acute lymphoma leukemia also affects the peripheral organs, such as thymus, mediastinum, lymph nodes, spleen, testes, bones, central nervous system, and soft tissues. As comparing with the B-cell type acute leukemia, T-cell type acute leukemia has less favorable prognosis in children. Let's start with our case. This is the case of the 7-year-old female patient with the mediastinal mass, and the morphology of the resected specimen shows diffuse proliferation of the small to medium-sized undifferentiated round cells, and on a background of the neoplastic cells, the tingible body macrophages can be easily recognized. On this power field, the tingible body macrophages, which causes so-called starry sky appearance, can be mistaken for the Burkitt lymphoma, but not in this case, because in Burkitt lymphoma we have large neoplastic cells, but in this case we have small to medium-sized neoplastic cells. Here on a higher power field, we can see that those nuclei are really overcrowded with a narrow, barely visible cytoplasm and a lot of mitotic features. And as you can see in picture, here can be recognized 6 to 7 atypical mitosis in this tumor. So immunohistochemistry, we do the first line immunohistochemistry, in which we have the CD45 positivity. This slide is just not shown here. And after that, we go to the lineage specific markers. Here we have a nice diffuse membranous staining of CD3, which is linear specific marker for T cells. And so we can recognize that this tumor is of T-cell origin. Then we can see also nice membranous staining of CD10, CD20, which is lineage specific for the B cell. B cells encountered only scattered mature small lymphocytes, B lymphocytes, so excluding B-cell origin of the tumor. Of course, high Ki67 labeling shows that we deal with the aggressive tumor, and it's typical for the acute lymphoma leukemia cells. The next immunostain which must be included is the marker which shows the blastic origin of the tumor cells. Here is shown the nice positive nuclear staining of the terminal deoxynucleotidyl transferase, TDT, which shows the blastic origin of the tumor cells. So after all those steps, we can easily recognize that we deal with the mediastinal mass with affection by the T-cell acute lymphoblastic lymphoma leukemia. And just to remember, the common type of extramedullary mass forming ALL in children is the T-cell type, T-cell ALL, and the common site of the T-ALL extramedullary mass is the thymus and mediastinum. So very commonly, children start to present their complaints, clinical complaints, connected with the large mediastinal mass. And of course, in differential diagnosis, except linear specific markers such as CD3 and CD20, the markers that shows the blastic origin of the tumor cells must be also included. As I showed at TDT, CD10, then CD99, CD1A also can be included in the protocol of differential diagnosis. That was the easiest case. Let's go to the another cases which are more or less more complicated than the lymphoproliferative disorders. The cases with the Ewingsarcoma, and let's see that according to the latest WHO classification, 4 diagnostic entities are under the umbrella of so-called undifferentiated small round cell sarcomas of soft tissue and bones. The first name is the Ewingsarcoma, which is characterized by the specific chromosomal rearrangements we will talk about later. And another 3 names of this group, so-called round cell sarcoma with Ewingsarcoma and non-ETC fusion tumors. Fortunately, those are very rare cases, and according to the latest WHO book, only 5 pediatric cases are described. CIC rearranged sarcoma, the next, is the tumor that is characteristic for the young adults and adult patients, not for the children. And the last case, sarcoma with BCOR genetic alterations, is less common in the rare than Ewingsarcoma, and with strike predilection to the male children, and they may be present at the birth. So it can be congenital tumor. So these 3 cases, of course, cannot be made solely immunohistochemistry and morphology. You need to do some sophisticated molecular testings. But now let's go to the Ewingsarcoma and see what is it. So Ewingsarcoma facts. Ewingsarcoma is a small round cell sarcoma with gene fusion, a specific gene fusion involving the Ewingsarcoma gene, the translocation of the Ewingsarcoma gene, and the fusion with one of the members of the ETC family transcription factors genes, usually FLI1. More than 90% of cases of the Ewingsarcoma characterized by the Ewingsarcoma gene and FLI1 fusion gene. Another 10% of cases are characterized by the fusion of the Ewingsarcoma gene with the ERK gene. So it must be also remembered that the Ewingsarcoma is the second common type of malignant bone tumors in children after osteosarcoma, and very importantly, pathologists must know and must remember that Ewingsarcoma can be extraskeletal without involvement of the bone. The peak incidence is usually second decade of the life, and interestingly, the incidence of the Ewingsarcoma varies with ethnicity, and the incidence in individuals of African and Asian descent is 2 to 3 times lower than those of European origin. Let's go to our case. Here you can see the medium-powered view of the tumor excised from the 12-year-old male patient who presented with the scapular lesion, the scapular neoplastic lesion. And here we can see the diffuse growth, a solid shed-like growth of the tumor cells consisting of medium to small-sized blue round nuclei with narrow cytoplasm. We can see a lot of atypical mitosis, some scattered lymphocytes, and of course individual tumor cells apoptotic changes. First-line immunohistochemistry shows that the tumor cells have very nice and intense membranous staining of CD99. At this point, a pathologist think about the possibility of the Ewingsarcoma, because CD99 is characteristic membranous, gives characteristic membranous intensive staining in the Ewingsarcoma, although it is completely non-specific. It is sensitive for Ewingsarcoma, but non-specific. So after this examination, we must go further in a second or third line immunohistochemistry protocol with including of different other antibodies. Here in this picture you can see very nice, moderate, sometimes strong nuclear positivity of the NKX2 antibody. It is very interesting and very helpful antibody, especially for those who deal with the pediatric pathology, and especially in this field of the differential diagnosis of small blue round cell tumors. It's a home domain transcription factor that plays a role in neuroendocrine and glial differentiation during embryonic development. But because of the specific fusion of the Ewingsarcoma and FLI1 gene, this protein is upregulated and can be easily visualized by the immunohistochemistry. So it is very characteristic positive staining for the Ewingsarcoma, although again must be mentioned that it is not completely specific for the Ewingsarcoma, as it can be seen in other tumors also. But in case if we have positive CD99, a specific morphologic picture such as small blue round cell tumor, it's a positive CD99 membranous staining. This positive staining of NKX2 promptly pushes pathologists to the possibility of diagnosis of the Ewingsarcoma. Another important marker in this field is the FLI1 antibody. FLI1 is a friendly leukemia integration transcription factor, is a protein encoded by the proto-oncogene FLI1 and is normally expressed in the endothelial cells, in hematopoietic cells, and of course in T lymphocytes. Yeah, and that is why the positive reaction is completely non-specific for the Ewingsarcoma. But in these settings, in case if we have positive CD99 and positive NKX2, positivity of FLI1 gene directly shows that we deal here with the Ewingsarcoma. Ewingsarcoma must show also negative staining of some important antibodies. This is the negative staining with the FOX2B antibody. We will speak about this antibody later on while we discuss the neuroblastoma. This is just to show you that we have a negative staining in case of the Ewingsarcoma. Interestingly, we found that the tumors of this group of small blue round cell tumors usually are characterized by the high mitotic activity. But in case of Ewingsarcoma, despite of the aggressive clinical course, usually tumor cells shows very low Ki67 label. Here you can see only 7, maybe 10% of neoplastic cells really shows positive Ki67 labeling. So remember that Ki67 in case of Ewingsarcoma usually labels less neoplastic cells than other tumor of this group. In a protocol, we including also the myogenic differentiation markers such as myogenin, but here you can see that the nuclei are negative because myogenin is a nuclear transcription factor specific for the myogenic origin. We see here in this particular case, we can see the dot-like membranous staining of the myogenin. which is disregarded and considered as a negative staining. So here a myogenic origin of the neoplastic cells can be easily excluded. And of course, don't forget to use simple special stains besides immunostains. The PAS staining shows here very nice cytoplasmic magenta inclusions that are really highly characteristic for the Ewingsarcoma. So in summary, in a differential diagnosis of Ewingsarcoma, we must have diffuse membranous CD99 staining, which is again...
Sorry, Dr. Mkhitaryan, do you hear me?
KX2 and 2 is a nuclear staining and must stain more than half nuclei of the whole tumor cells. It is very sensitive, but again non-specific. FLI1 also nuclear staining, again sensitive but non-specific, and only constellation of these three markers along with the negativity with FOX2B, low Ki67 label, and positive PAS cytoplasmic granules makes the diagnosis of Ewingsarcoma possible in the patients. Let's go to another entity of this group. This is rhabdomyosarcoma, a very difficult tumor from the point of view of differential diagnosis, and it really can cause really severe headaches for the pathologists and residents. So current WHO classification distinguishes 4 types of the rhabdomyosarcoma, namely embryonal, alveolar, pleomorphic, spindle cell sclerosing rhabdomyosarcoma. Rhabdomyosarcoma is the most common soft tissue sarcoma in children. And in children, it must be noted that embryonal and alveolar rhabdomyosarcomas are most common types. And other 2 types, that's pleomorphic or sclerosing spindle cell rhabdomyosarcomas, are not just typical for the children and can be seen in adults and elderly patients. And for embryonal rhabdomyosarcoma, the commonly affected sites are the head and neck and genitourinary system. For alveolar rhabdomyosarcoma, the common sites of involvement are the extremities. Let's go to our case of the rhabdomyosarcoma. This is the picture of the solid alveolar rhabdomyosarcoma from the soft tissue taken from the 9-year-old female patient with the pelvic mass. Here, of course, by the histology, we cannot at once recognize that we deal with the myogenic origin, because we see the same, more or less the same picture, that is diffuse solid growth of the small to medium-sized neoplastic cells, which have an uneven distribution of the chromatins, hyperchromasia of the cells, nuclear overcrowding, many atypical mitosis, and individual tumor cell apoptosis and necrosis, which is commonly seen picture in all types of the small blue round cell tumor. This is also the case. Some clear cell changes in the cytoplasm of the tumor cells, which is not completely specific for the rhabdomyosarcoma. And the tumor, this is also the case. Some clear cell changes in the cytoplasm of the tumor cells, which is not completely specific for the rhabdomyosarcoma. And we do the immunostain, and the first line of immunostain shows that we do not deal with the lymphoproliferative disease, because the tumor cells are CD45 negative, and CD45 highlights the lymphoid, scattered lymphoid cells within the tumor tissue. Another marker which can make things complicated and create a mess is a CD99. So we know that CD99 is a specific marker for the Ewingsarcoma, but we noted that it is not completely specific because it can be seen in any entities also, as shown here. In some cases of the rhabdomyosarcoma, we can see the moderate membranous staining, although it must be also noted that in case of the rhabdomyosarcoma, we have some cytoplasmic accentuation of the staining with this marker. Another marker which also causes very difficulties and which causes difficulties and can make things much more complicated is the CD56, which is a very specific marker, sensitive marker, not specific, sensitive marker for the cells of neuroblastic origin. So after this, there's two pictures. But the pathologist must recognize at least two and must rule out at least two diagnostic entities, namely Ewingsarcoma, because we have positive CD99, and neuroblastoma, because we have very nice and intensive CD56 membranous staining in all tumor cells. So we go further and do our staining that we have already known, NKX2 and 2. We see that we do not have any positive nuclear staining with this antibody, so Ewingsarcoma can be excluded at this point. The next, our staining that we have already known, NKX2 and 2. We see that we do not have any positive nuclear staining with this antibody, so Ewingsarcoma can be excluded at this point. The next antibody is FOX2B, which I mentioned is typical for the neuroblastic cells, but despite positivity on CD56, FOX2B is negative. So neuroblastoma also can be excluded in this case. Next step, immunohistochemistry, we must include more antibodies, and first of all to differentiate myogenic origin. Here shown the desmin, very nice staining, cytoplasmic intensive staining of the desmin. It must have this kind of the reaction, very intensive cytoplasmic staining, because desmin very often causes non-specific, moderate to very weak cytoplasmic staining in any kind of the tumors. Even in some carcinoma shows very weak cytoplasmic staining, but those stainings must be disregarded, and very strong, really strong cytoplasmic staining with desmin must be encountered in this case and must be estimated as a positive for myogenic differentiation. And just to be sure that we deal with the rhabdomyosarcoma, we do more specific immunostains that highlights the transcription factors, nuclear staining, myogenin. Here you can see the positive nuclear staining with myogenin, and positive nuclear staining with MyoD1, which confirms the rhabdomyoblastic origin of the neoplastic cells. So in summary, rhabdomyosarcoma must have a minimum constellation of the positive biomarkers in order to be called the rhabdomyosarcoma. Those includes desmin, myogenin, and MyoD1 positivity, and of course it must be negative for other markers. First of all, negative for NKX2 and 2 and FOX2B to exclude the Ewingsarcoma and neuroblastoma. As for the CD56, it must be remembered that there are clinical research data and publications that shows that CD56 can be really positive in the cases of rhabdomyosarcoma, especially alveolar type of the rhabdomyosarcoma, and this must be remembered by the pathologists and the residents also. CD99 is not specific and not sensitive for rhabdomyosarcoma. It just stained, and it must be remembered that in case to regard this as a positive, we must have very intense membranous staining, and if we have the cytoplasmic staining, we just disregard the positivity. As for the FLI1 gene and FLI1 antibody, we seen previously that FLI1 is characteristic and sensitive marker for the Ewingsarcoma, and sometimes in rhabdomyosarcoma, FLI1 can be also positive. And I found it very interesting research data and publication from the early 90s of the last century that shows FLI1 positivity in rhabdomyosarcoma, possibly highlighting the very specific genetic abnormalities and translocation in those cases with involvement of the FOXA gene and FLI1 gene. Let's go to another name of these entities, of the small bowel round cell tumors, to the neuroblastoma. And let's see first of all that under the umbrella of peripheral neuroblastic tumors, according to the latest WHO classification, we have 4 entities, namely ganglioneuroma, ganglioneuroblastoma, neuroblastoma, ganglioneuroblastoma nodular, and intermixed and composite ganglioneuroblastomas. And neuroblastoma is a highly malignant cell characteristic for the children and is a peripheral neuroblastic tumor of the neural crest origin with less than 50% of Schwannian stromal content. And the primary sites follow the migration of the neural crest cells during their embryonic development and include the adrenal glands. First of all, the 40% cases can be seen with affection of the adrenal glands. It can be presented as an abdominal mass, thoracic mass, pelvic mass, and head and neck mass, such as sympathetic ganglia of the head and neck region. This is the picture of the tumor mass resected from the adrenal gland of 6-year-old female patient. Here we can see also this more or less the same picture, the diffuse shed-like growth of these small, round, undifferentiated neoplastic-looking cells with little amount of the stroma, and here must be remembered that the neuroblastoma is characterized by the development of the so-called neuropils. You can see here as a light eosinophilic stromal-looking component, and around which we have the neoplastic cells, which gives the characteristic pattern of rosette-like structures. Here under high magnification, also you see some tumor necrosis area, geographic necrosis area, which is typical for the neuroblastoma because it's highly aggressive and malignant tumor. And sometimes pathologists is obliged to deal with the fine needle aspiration specimens. Here on the fine needle aspiration, the neuropils can be easily and very nicely seen on a background of relatively cohesive neoplastic atypical round cells. CD45 excludes the hematopoietic origin of the neoplastic cells. Here you can see some scattered small amount of the lymphoid cells that are positive for CD45, but the tumor cell neoplastic cells are negative. CD56, it is highly characteristic feature that the neuroblastic cells has a very intense membranous staining with CD56, and from this point pathologists start to think about the possibility of the neuroblastoma. And then we include very important antibody FOX2B. It's paired like HOMebox2B is a transcription factor located in the chromosome 4 and is a crucial role in the development of autonomic nervous system, especially those of noradrenergic origin. That is why FOX2B highlights the tumors that are coming from this part of the autonomic nervous system. As in this case, you can see very nice nuclear staining in the case of neuroblastoma, but other ganglioneuromas, ganglioneuroblastomas, and pheochromocytomas also can show the positive nuclear staining with this antibody. It is highly specific and highly sensitive for cells of neuroblastic origin. I found very interesting field in pediatric pathology, and I suggest all pathologists and residents that work in a field of pediatric pathology start to use this antibody in case if you have to recognize ganglion cells in case of Hirschsprung disease also. I found it very helpful, and it really very nicely highlights the ganglionic cells in the Hirschsprung disease. So let's come back to our neuroblastoma case. Here we can see very nice intensive nuclear staining of the FOX2B. This is just enough with the histologic picture to show that we deal with the neuroblastic cells and neuroblastoma. NKX202, as expected, is negative. It's specific for the Ewingsarcoma, we have already discussed. And neuron-specific enolase is nicely highlights the cytoplasm of the neoplastic cells in neuroblastoma. So in summary, we can conclude that in order to recognize and diagnose the neuroblastoma, we must have CD56, NSEA positivity, and of course FOX2B, because it's highly sensitive and highly specific marker for peripheral neuroblastic tumors. These slides highlights our summary of our discussion, and as for the acute lymphoblastic leukemia cases, I shown the red color shows the must-have positive staining of the antibodies in order to diagnose or to differentiate tumors in this group. So in case of acute lymphoblastic leukemia, lymphoma, it's not a problematic, it's CD45 positive, and that's it. You have to just do some lineage specific and blastic origin markers in order to get the correct diagnosis. As for the Ewingsarcoma, rhabdomyosarcoma, and neuroblastoma. So the Ewingsarcoma again is characterized by the CD99, NKX202, FLI1 positive staining, low Ki67 labeling, and positive cytoplasmic pus positive vacuoles. And other markers such as FOX2B must be negative in case of the Ewingsarcoma. Rhabdomyosarcoma characterized by the positivity with desmin, myogenin, MyoD1. It usually has a high Ki67 label. It must be negative for NKX202 and FOX2B. CD99, CD56, and FLI1 can cause really very diagnostic difficulties in our routine work, but it must be remembered that based only solely on positivity of these antibodies, it's not reliable for the differential diagnosis. As for the neuroblastoma, you can see that the red color highlights FOX2B only in this group. So let's remember again that the FOX2B is a highly specific and sensitive to differentiate the neuroblastic origin of the tumor cells. And of course, let's remember again that in immunohistochemistry, nothing is 100% specific and sensitive. And in case of the differential diagnosis of small blue round cell tumors, immunohistochemistry assessment must include a protocol of different antibodies that I have mentioned in my lecture. I hope my lecture will be helpful for all of you, or all working residents and pathologists. And thank you very, very much.